Bismillahirrahmanirrahim. Quote of the day is, the hearts of others are as real as yours. Be gentle. Assalamu alaikum everyone. My name is Dr MOMENA ZIA. I'm a PGR in Community Medicine Department. I'm going to present the topic of dengue under kind supervision of my supervisor, Professor Dr. SAIRA AFZAL. The agenda of today's meeting would be introduction, epidemiology, pathophysiology, clinical manifestations, diagnosis, prevention, public health strategies and challenges faced, new advances, MCQs with key. Now, learning outcomes. At the end of this meeting, participants will be able to define dengue and its causative agent, understand the epidemiology of dengue, identify clinical manifestations and diagnosis, discuss preventive measures and control strategies, explore public health challenges in managing dengue. Now, what is dengue? It is a mosquito-borne viral infection which is caused by dengue virus, Dengue. It's an RNA virus which has 4 serotypes, Dengue1 to Dengue4, which belongs to the flavivirus genus. It is transmitted primarily by the bite of infected Aedes aegypti mosquitoes and occasionally by Aedes albopictus. Epidemiology. Dengue fever is a significant global public health challenge, particularly in tropical and subtropical regions. The disease epidemiology is shaped by environmental, biological, and socioeconomic factors. Moving on to the global burden, it's an endemic in over 100 countries across Asia, Africa, America, and the Western Pacific. The WHO estimates about 390 million infections occur annually, of which approximately 96 million are symptomatic. Key epidemiological features. The agent is a dengue virus, 4 serotypes, Dengue1, Dengue2, Dengue3, and Dengue4. Infection with one serotype, it provides a lifelong immunity to this serotype, but increasing the risk of severe disease upon subsequent infection with other serotypes. That is the hemorrhagic dengue, which is life-threatening. Number 2 is vector. The Aedes aegypti, which is the primary vector, and Aedes albopictus, which is the secondary vector. So the day-biting mosquitoes that thrive in urban and semi-urban environments. Host, humans are the primary reservoir for dengue transmission, and monkeys, they also act as secondary reservoirs in sylvatic transmission cycles. So the transmission cycle is of 2 types, the urban cycle and the sylvatic cycle. In urban cycle, the mosquito to human transmission occurs, while in sylvatic cycle, it involves a non-human primates and forest-dwelling mosquitoes. So in Pakistan, the peak transmission occurs during and after the rainy season due to the increased mosquito breeding in stagnant water. And what is the situation in Pakistan? It has an increased frequency of outbreaks since 2011, and by the looking at the fresh statistics, by the 2nd September 2024, Pakistan has reported a total of 2,795 new dengue cases in this year, with Balochistan being hardest hit region, registering the highest number of cases in a single week. So provinces most often affected are Punjab, Sindh, Khyber Pakhtunkhwa. Moving on to the risk factors, there are certain environmental, biological, and socioeconomic risk factors for developing dengue. Environmental factors include warm temperatures like 25 to 30 degrees Celsius. It favors the mosquito survival and viral replication. And urbanization, deforestation, it leads to increased breeding sites. Biological factors are pre-existing immunity to one serotype. It increases the risk of a severe dengue with subsequent infections. Now, the socioeconomic factors is poor water management, inadequate housing, and limited access to healthcare exacerbates the burden in low resource settings like Pakistan. Now, the epidemiological trends, it has an expanding distribution with recurrent epidemics, and there are reports of severe dengue cases. Now, how the expanding distribution has been occurring by means of globalization, urbanization, and climate changes. These are expanding the dengue's geographic range recently. Recurrent epidemics, outbreaks occur every 3 to 5 years in endemic regions due to the serotype dynamics. Severe dengue, increased frequency of severe dengue is linked to secondary infections and changes in serotype dominance. Now, moving on to the life cycle of this virus, we'll see that the female mosquito, it needs blood for the egg production. These eggs are then laid most times slightly above the water levels. Hence explains the presence of water for the replication and production. When covered with water, larvae, they emerges from eggs. Then the first larval stage, second larval stage, third larval stage, and fourth larval stage occurs. In these stages, molting occurs, which means the larva sheds skin for its growth. Then it is converted into pupa, and then that pupa it results in the formation of an adult. These adults mate, and then the cycle continues. Now, the pathophysiology is that when the mosquito bites, the virus enters via this mosquito bite in its host. This virus it infects the white blood cells and the lymphatic tissues, or also the RBCs. Release of the cytokines that leads to the plasma leakage, hemorrhage, and shock in severe cases. So the last point it mostly occurs in case of if a person has been already exposed to dengue virus before. Now, what are the key features of dengue in terms of its clinical manifestations? We see a febrile phase and a critical phase before recovery, mostly. So, in febrile phase, it is characterized by the sudden onset of high fever, headache, retroorbital pain, muscle and joint pains, which is also known as a breakbone fever, mild bleeding, which occurs through gums or nosebleeds. There is a particular rash on skin. There is a then moves on to the critical phase, which occurs in severe cases, which is characterized by plasma leakage, severe bleeding, and organ impairment, potentially leading to dengue hemorrhagic fever (DHF) or dengue shock syndrome (DSS). In most of the cases, the febrile phase is followed by recovery. So this recovery phase, in this recovery phase, there is a gradual improvement in symptoms with the reabsorption of the leaked plasma. Now, how the WHO classifies dengue? It is classified as dengue without warning signs or dengue with warning signs, which includes abdominal pain, persistent vomiting, fluid accumulation, mucosal bleeding, lethargy, hepatomegaly, and rising hematocrit with falling platelet count. Severe dengue, some severe plasma leakage occurs, severe bleeding or an organ failure can be seen in these patients. Now, how we diagnose dengue? Accurate and timely diagnosis of dengue is essential for effective clinical management and public health response. Lab tests for dengue are categorized into direct methods and indirect methods. Well, now, what are the direct methods? Direct methods are those methods that detect the virus or its components, like viral antigen detection test, which is NS1 antigen test, reverse transcriptase polymerase chain reaction RT-PCR, and virus isolation, which is cell culture. These are the direct methods. Now, moving on to the indirect methods, these detect the immune response to the virus, like IgM antibody presence, which can be tested by the test of MAC ELISA, IgM antibody capture ELISA. Hematological and biochemical parameters are also very important in diagnosing dengue. This is the key test which has been done in Pakistan to diagnose dengue along with the NS1 antigen test. So the hematological and biochemical parameters are thrombocytopenia, which is a low platelet count, less than 100,000 cells per mm cube. Hemoconcentration, which is elevated hematocrit, more than 20% of increase is seen, and it is indicative of a plasma leakage and severe dengue. So we have to see the hematocrit levels along with the platelet levels, and leukopenia is seen, which is the reduced white blood cell count. Now, what is the summary? This is the summary of laboratory techniques. NS1 antigen, the timing is 0 to 7 days after the onset. Mostly it is seen in the plasma in 7 days after the onset of symptoms. Serum is taken. It has the advantage that it shows the early diagnosis of a disease. However, it has a limitation as it has reduced sensitivity in later stages. So early stage diagnosis is possible because of the NS1 antigen. Then RT-PCR, it turns positive in up to 0.5 days after the onset of symptoms. Again, serum, it can be tested on serum. It detects all the serotypes in viruses. But it requires specialized equipment. IgM ELISA, less than 5 days after the onset. It was also tested on serum. It shows a recent infection, but the cross-reactivity with other flaviviruses can be seen. Next, moving on to IgG ELISA, it is positive after 7 days of secondary infection or secondary infection. It can be tested on serum, and it is mostly because of the past exposure or a secondary infection, but it is not specific to a recent infection. Conclusion. So a combination of antigen, molecular, and serological tests is recommended for a comprehensive dengue diagnosis. Early phase tests such as NS1 and RT-PCR are crucial for rapid detection, while serological tests they provide an insight into the immune response and secondary infection. Now moving on to the management of dengue case. Mostly, the diagnosis is based on the diagnosis is a presumptive diagnosis. We presume that the person, if it has a history of travel or may live in an area which is endemic to this fever, uh, there are and have the following symptoms of nausea, vomiting, rash, aches and pains, or any warning signs of abdominal pain, vomiting, positive tourniquet test, and leukopenia. So they are diagnosed as a case of dengue. Or if they have the warning signs, like intense continuous abdominal pain or pain with palpating abdomen, persistent vomiting, fluid accumulation, mucosal bleeding, altered mental status, hepatomegaly, or progressive increase of the hematocrit. So these patients, they are divided into three categories. If there are no warning signs, they are treated in the outpatient management, and they are categorized as group A. They are mostly counseled about using there is no treatment of dengue. Mostly supportive treatment has been done. So in the outpatient department, they are said to be controlling the fever. They have to hydrate themselves, and they are guided about in this respect. So if the patients are now the patients if the patients presents with the warning signs or severe dengue or any of the following, they are grouped as group B, and they are treated as inpatient management in which the fluids are given to the patient. And if the patients have shock or clinical significant bleeding, they are admitted in the ICU for intensive care management, and they are grouped as group C. Now, moving on to the control and prevention of dengue. Dengue control, it focuses on preventing mosquito bites or controlling mosquito populations and enhancing community awareness. Effective prevention requires a combination of individual, community, and government level efforts. Move on to vector control. Since Aedes aegypti is the primary vector, controlling its population is the most effective way to prevent dengue, which is number one is eliminating the breeding sites, source reduction by removing standing water in containers like tires, flower pots, buckets, and discarded items, or covering the water storage containers with lids or tight covers, changing water in pet dishes, vases, and plant saucers weekly. Moving on to the biological control, which has been done in some developed countries, like use of fish such as guppies or larvivorous organisms, which ingest the larva of dengue virus in water containers. Introduction of Wallacea infected mosquitoes to reduce dengue virus replication in Aedes mosquitoes. So what has been done in Pakistan is chemical control, like insecticide spray in outbreak-prone areas, use of larvicides in water reservoirs, fogging to kill adult mosquitoes during epidemics. Then personal protection has been advised to people, like use of insect repellents, wear long sleeved clothing and long plants, uh, use mosquito nets, particularly for infants and older individuals. So this is a pictorial representation of all the prevention instructions for like applying the mosquito repellent, avoid outdoors, use mosquito nets, and etc. Another most important point in control and prevention of dengue is vaccination. So the development of the vaccines has been challenging due to the presence of four dengue serotypes, and these four serotypes further have different genotypes, which require broad protection to avoid severe disease upon secondary infections with different serotypes. Here's an overview of available vaccine and ongoing research. Number one is CYD-TDV, which is also called as Dengue Zia. This is the first dengue vaccine which is approved by the World Health Organization in several countries. The target age group is 9 to 45 years of age. So it is a tetravalent live attenuated recombinant vaccine. It protects against all the serotypes of dengue virus. This vaccine, it is safe in previously infected individuals. So moderate protection has been provided against severe dengue and hospitalization. It is recommended for individuals with documented past dengue infection. And there are certain limitations as a risk of antibody-dependent enhancement, ADE, leading to more severe disease in dengue-naive individuals. Moving on to the other one, which is TAK003 or Qdenga. It is approved in some regions, including the European Union in 2022. This is also a tetravalent live attenuated recombinant vaccine. Unlike Dengue, Qdenga can be given to prevent disease in people who have never been infected. So the efficacy is demonstrated to be having a broad protection against all four serotypes in clinical trials, including dengue naive and previously infected individuals, which has already been discussed. The age group is 4 to 60 years of age. The key advantage is it is suitable for broader population without prior serological testing. Another one which is in clinical trials is Denvax, which is dengue tetravalent vaccine manufacturer. The it is based on the same technology as Qdenga. It is in late stage clinical trials designed to be effective regardless of previous exposure to dengue. So there are going to be researches on live attenuated and subunit vaccines like messenger RNA vaccine, and some more vaccines can be seen in future too. Now, what is the WHO recommendation regarding this vaccination? It is a part of integrated dengue prevention and control strategies, including vector control and community education all around the world. Also, CYD-TDV dengue ZIA, it is recommended for individuals with confirmed prior dengue exposure in high-risk areas to reduce the severe dengue and hospitalization. However, there are certain challenges that has been faced, which is because of the vaccine hesitancy. Incidents related to dengue ZIA in the Philippines raised concerns about safety affecting public perception. Also, there is strain variation, which is maintaining the efficacy against all serotypes remains difficult because there are different different genotypes of the virus. Despite the global availability of dengue vaccines, such as dengue ZIA and Udenga, these vaccines, they are not yet commercially available in Pakistan. Now, considerations for public health. Seroprevalence studies critical to determine the proportion of the population with past dengue exposure before large-scale vaccination programs. Cost effectiveness, it varies based on region endemicity and healthcare resources, combination with preventive measures. Vaccination complements mosquito control programs such as using insecticides, treated nets, and eliminating standing water. Moving on to the community and environmental management of the dengue cases, we see that the community engagement for cleaning surroundings and eliminating mosquito habitats, public education is also very important, and campaigns on identifying breeding sites and preventive measures, encouraging proper disposal of solid waste to prevent water accumulation. So, what are the control strategies during an outbreak? Number one is surveillance and monitoring, like regular monitoring of the dengue cases and mosquito populations with the use of geographic information system for hotspot mapping. There is a rapid response teams that mobilize health workers and community volunteers to conduct fogging and door-to-door awareness campaigns. And then there is the case management, which ensure the access to healthcare facilities with trained personnel to handle severe dengue cases. They use IV fluids judiciously for fluid replacement and avoid unnecessary use of antibiotics. So there are certain policies for the public health for dengue control. One is vector control legislation. One is number two is integrated vector management. Number three is awareness campaigns, the details of which has previously discussed. The policy framework and public health interventions, international guidelines, WHO Global Strategy for Dengue Prevention and Control 2021 to 2025, National Dengue Action Plans, which strengthens the vector control programs, integrate dengue prevention into urban planning and healthcare policies, and educate the public for their behavior change, which includes the personal protection, public awareness campaigns to reduce mosquito breeding sites. There should research in future directions. Number one is technological innovations, which is the use of drones or AI for surveillance and predictions of outbreaks, genetically modified mosquitoes for vector control, and public health research gaps, effectiveness of combined vaccination and vector control strategies, also long-term impact of climate change on dengue epidemiology. These are the gaps that are seen. Now moving on to the recent advances in dengue. This is the article which is taken from Journal of Child Health Sciences, published in 2024. It is a systematic review of dengue vaccines, CYD, TDV, dengue, ZIA, and Qdenga in children, efficacy, immunogenicity, safety, and challenges. This is the abstract. So the results mostly showed. So basically the vaccination, the effects of vaccine has been seen on children, and the results shows key findings regarding vaccine efficacy, immunogenicity, and safety in children are summarized in this review. CYD-TDV, despite its efficacy in dengue experienced individuals, long-term safety data demonstrated that this vaccine increases the risk of more severe symptoms upon dengue infection in individuals who were dengue naive and in children less than 9 years of age. Qdenga RTA case 003 has shown promising results Conclusion: dengue vaccine represent a promising tool for dengue prevention in children. While vaccine efficacy and safety issues remains ongoing, research and innovation hold promise for the safer and more effective dengue vaccines development. This is another article, which is the serotype and genomic diversity of dengue virus during the 2023 outbreak in Pakistan. It reveals the circulation of genotype 3 of dengue 1 and cosmopolitan genotype of dengue 2. So, in the year of 2023, the serotyping revealed dengue 1 as the predominant serotype, which is 84.7%, followed by dengue 2. Whole genomic sequencing of 18 samples, they showed that dengue 1 samples were closely related to Pakistan outbreak samples of 2022 and approximately more than 98% with USA. Also, there no co-infection with dengue serotypes has been seen. Comparisons with previous dengue 1 sequence highlights the genetic variations affecting viral replication efficiency. So moving on to the MCQs. Number 1, a 35-year-old man from Lahore visits a rural area during the monsoon season. After returning home, he develops a high fever, severe headache, muscle pains, and a rash. He reports that mosquitoes were prevalent in the area where he stayed. Considering the most likely diagnosis of dengue fever, which of the following best describes the mode of transmission of dengue virus in this patient? A, bite of female Anopheles mosquito. B, bite of male Aedes aegypti mosquito. C, bite of female Aedes aegypti mosquito. D, contaminated water, food consumption. And E, direct human-to-human transmission. Anyone? So the answer is Charlie, which is bite of a female Aedes aegypti mosquito. Number 2 is a 25-year-old woman presents to the emergency department with a history of high fever for the last 4 days, severe headache, retroorbital pain, muscle and joint pain, and a maculopapular rash. She also reports nausea and mild abdominal discomfort. On examination, she has petechiae on her arms and mild hepatomegaly. Based on the clinical presentation, which of the following additional findings would be consistent with a diagnosis of dengue fever? A is profuse diarrhea with rice water stools. B is severe thrombocytopenia with plasma leakage. C is painless lymphadenopathy and night sweats. D is productive cuff with cavitation on chest x-ray. And E is enlarged spleen with a positive at all test.
B.
Yes, B is the correct answer. Moving on to third, a 30-year-old man presents to the outpatient department with a history of high-grade fever for the last 3 days, severe headache, muscle pain, and a rash. He reports recent travel to the area experiencing a dengue outbreak. His physical exam reveals petechiae and positive tourniquet test. The attending physician suspects dengue. Which of the following is the most appropriate initial diagnostic test for confirming the diagnosis during the early phase of illness? A is dengue IgG serology, B is blood culture, C is NS1 antigen, D is dengue IgM ELISA, and E is CBC complete blood count.
C.
Yes, Charlie is the correct answer. 4, a 28-year-old woman is admitted to the hospital with a 3-day history of high fever, severe headache, retroorbital pain, joint pain, and muscle pain, and a maculopapular rash. Her physical exam reveals petechiae and mild hepatosplenomegaly. Lab investigations are ordered to assess her condition. Which of the following blood finding is most characteristic of a dengue fever? A, elevated neutrophil count and normal platelets. B, leukocytosis and elevated hematocrit. C, thrombocytopenia and elevated hematocrit. D, decreased hematocrit and elevated white blood cell count. E, increased erythrocyte sedimentation rate and normal hematocrit.
C.
G. Yes, Charlie is the correct answer. A public health researcher is explaining the replication cycle of dengue virus during a training session on vector-borne disease. He describes how the virus infects human host cell after being transmitted by a mosquito bite and highlights the key stages involved in viral replication. Which of the following correctly represents a critical step in the life cycle of a dengue virus after it enters a human host? A, the dengue virus integrates into the host cell's DNA for replication. B, the virus binds to host cell receptors and enters by receptor-mediated endocytosis. C, the virus uses the nucleus for RNA replication and protein synthesis. D, the virus directly uses host ribosomes without forming a replication complex. And E, the virus exits the host cell via budding without affecting the host cell membrane. So the correct answer is beta. 6. A 12-year-old boy from a dengue endemic region visits a clinic for a routine health checkup. His mother asks the physician about available vaccines to prevent her son from dengue fever, as he has already been a confirmed diagnosis of dengue infection 2 years ago. So the physician explains that a dengue vaccine can be considered based on his history and current guidelines. Which of the following statements best reflects the appropriate recommendation for dengue vaccine in this case? A dengue vaccination is recommended for all children above 1 year of age, regardless of previous infection. B, dengue vaccination is contraindicated in individuals with a previous history of dengue. C, dengue zia is recommended only for individuals who have lab-confirmed prior dengue infection. D, dengue zia provides lifelong immunity after a single dose in dengue endemic areas. E, dengue vaccination is recommended annually during peak dengue seasons. Sorry. So the correct answer is Charlie, which is the dengue vaccine is recommended only for individuals who have lab-confirmed prior dengue infection. 7. A public health team is planning to introduce a dengue vaccination program in a tropical country experiencing frequent dengue outbreaks. Despite the availability of a licensed dengue vaccine, dengue zia, the program faces severe challenges. During a strategic planning session, the team identifies critical issues to address for successful implementation. Which of the following represents a key challenge in implementing a dengue vaccination program? A, difficulty in identifying individuals at risk of dengue infection. B, risk of severe dengue in individuals vaccinated without prior dengue exposure. C, ineffectiveness of the vaccine against all four serotypes of the dengue virus. D, requirement for annual booster doses to maintain immunity. E, lack of vaccine approved by WHO. So the correct answer is beta. 8. A public health department in a dengue endemic region has noticed an alarming increase in the number of dengue cases over the past year, leading to a surge in hospital admissions and increased mortality. So the department is now evaluating the broader public health impact of dengue in the region. Which of the following long-term consequences of frequent dengue outbreaks is most likely to be observed in this area? A decreased burden on healthcare infrastructure due to better mosquito control programs. B, long-term economic strain on families due to increased healthcare costs and lost workdays. C, increased life expectancy due to improved vector control measures. D, reduced incidence of other vector-borne diseases due to more effective insecticide use. And E, decreased public awareness of preventive measures due to recurring outbreaks. So the correct answer is B. The government of Pakistan is developing a comprehensive public health policy to reduce the burden of dengue fever, particularly in urban areas where mosquito breeding sites are abundant. During a policy planning session, key stakeholders are discussing potential interventions to address this issue. Which of the following policy measures would be most effective in reducing the incidence of dengue in the long term? A, launching a nationwide awareness campaign to encourage people to avoid mosquito bites. B, establishing the year-round vector surveillance and control programs, including door spraying of insecticides. C, providing free dengue vaccination for all children under 12 years of age in high-risk areas. D, focusing only on treatment of dengue cases in hospitals without preventive measures. E, introducing a nationwide ban on the importation of used tires, a common mosquito breeding site.
A.
The correct answer is B. Number 10, public health expert in Pakistan is reviewing recent advances in the field of dengue control and prevention. During a presentation, she discussed new technologies and approaches that are being integrated into public health programs, which are the following recent advances in dengue control has shown the most promise in reducing mosquito populations and preventing the spread of the virus. A, development of a dengue-specific antiviral treatment for early-stage infections. B, introduction of genetically modified mosquitoes to reduce mosquito population. C, widespread distribution of mosquito nets treated with insecticides in urban areas. D, implementation of a national dengue vaccination program for all children. And E, use of mobile applications to track dengue cases and inform the public about the outbreaks.
B.
Yes, B is the correct answer. This is the key of the MCQs. And this is the link of the channel where the presentation will be uploaded. Thank you.